urolithiasis. Okay, so it is more common in men. Okay, so calcium stone are usually composed of two calcium salt, okay, calcium phosphate and calcium oxalate, and these are the most common renal calculi. Okay, so calcium stone are most common renal calculi. Okay, so next is uric acid stone. Okay, so uric acid stone form in low pH acid, so low pH. Okay, okay, and with patient with hyperuricosuriia, uric acid, so hyperuricosuriia. Okay, so this result in purine metabolism from cellular breakdown. Okay, or tumor lysis or excessive protein intake. So they will ask which stone is related to tumor lysis, so uric acid. Okay, okay, so struvite stone. Okay, so this is also called as infection stone. Okay, or known as magnesium ammonium phosphate. Okay, so remember struvite is sepsis, infection, sepsis. Okay, and other name is magnesium ammonium phosphate. Okay, MAP, magnesium ammonium phosphate. And there is a specific bacterial infection, that is proteus, klebsiella and staph. So staph aureus and staph epidermidis. Okay, okay. So next is cystine stone. Cystine stone form, this is autosomal recessive. Remember, it is autosomal recessive and abnormality in cola amino acid. What is cola amino acid? C for cysteine, O for ornithine, L for lysine, A for arginine. Remember, okay, important. So investigation we do CT scan. So which two stone are not detected in CT scan? So indinavir and retinavir. Okay, so basically mnemonic is lux, lux, lucent is uric acid and xanthine. Okay, not visible. Okay, okay, so when there is a high temperature more than 101.5 Fahrenheit, hypotension and tachycardia, mainly patient present like this. Okay, so other complaint patient also comes with the abdominal and flank or back pain with wax and wane, but cannot resolve with position changes. Okay, important. Okay. And there is a investigation of choice for renal stone is or ureteric stone is non-contrast CT. Okay, of abdominal and pelvis. So remember, it's abdomen also and pelvis. Okay, because the kidney is abdominal and then ureter and pelvis and then bladder. Okay, so it's CT non-contrast. So remember, is non-contrast. Okay, and 85% of calculi are radio opaque. Okay, okay, so for management we will give IV ketorolac or opioid analgesic. Okay, okay, so upper tract UTIN obstruction should undergo expeditious drainage with either cystoscopic urethral stent placement or percutaneous nephrostomy tube. Okay, okay, so most common drug used in renal stone is tamsulosin, that is alpha 1 blocker. Okay, important question. How it works? It relaxes urethral smooth muscle. Okay, okay. So in calcium based stone, that is oxalate or phosphate, you should increase the fluid intake. How much? More than 2 liter of urine output daily. Okay, and there should be no change in calcium consumption. Okay, patient should consume as they are consuming calcium normally. Okay, and consume recommended daily allowance of dietary calcium. Okay, and dietary level of sodium, food high in oxalate and animal protein should be avoided. Okay, or reduce. Okay, next is in uric acid stone, it is dissolved by the raising the urinary pH level with use of alkalinating agent. Okay, okay. So elective management. So SWL, that is shock wave lithotripsy. Okay, so it is a transcutaneous procedure. Okay, so with this shock wave, we create fragmentation in the stone. Okay, create positive and negative pressure that causes stone fracture. Okay, so non-opaque stone larger than 2 centimeter of certain ureteric calculi should not be treated with this method. So ESWL can treat less than 2 centimeter of stone. Okay, okay. And the complication of ESW is it's very important. Renal injury, stress effect. Okay, street of stone. This is very important. Ask 1,000 times. Okay, you will may get the X-ray picture. Okay, and then hypertension and chronic kidney disease. Okay, so these are the complication of ESWL. Okay, hypertension also. So smaller renal stone and ureteric calculi can be managed through ureteroscope. Okay, okay. So most common stone treatment is laser lithotripsy. Okay, okay. So complication of ureteroscopy include acute ureteral perforation, avulsion, UTI, and late ureteral stricture formation. Okay, for larger stone and proximal ureteral stone we should do PCNL. So P for proximal, actually P percutaneous, but remember P for proximal stone. Okay, and why PCNL is preferred? Because it has got larger working endoscope and better instrumentation for stone fragmentation. Okay, okay. So post-operative renal drainage is required. Okay. So advantage of PCNL that numerous intracorporeal lithotripsy devices are available. Okay. So it is more invasive in nature. So because of this, there may be sepsis, renal hemorrhage, and renal collecting system injury. Okay, the complication may be hydrothorax and pneumothorax. Okay, and this is the picture of ureteral stone. You may get picture based question. So ureteral stone. Okay, okay. Thank you.